Honor to stand before you as a part of the 12th National Summit of Health and Population Scientists in Nepal, an event that brings together brightest minds shaping the future of health in our country. I hope you all had a refreshing tea and coffee break and are re-energized for the sessions ahead. We will now proceed to 11th parallel session, which focuses on aging and geriatric health, areas that remain central to improving health outcomes in our communities. A very warm welcome to all our presenters, participants, and guests. We are delighted to have you here with us today. We are pleased to have two distinguished experts chairing this session. Let me begin by introducing our chairs. Professor Dr. Lochana Shrestha. She is a leading expert in preventive medicine and public health, over 25 years of experience and over 15 years of experience in geriatrics. She is the head of Department of Community Medicine at the National Army Institute of Health Sciences and Director of Planning, Research and Development. She is affiliated with NHRC since 2007. She is a former Ethical Review Board member of NHRC. She holds degree in medicine, public health and genetics from institution in Bangladesh, India and Australia. Dr. Shrestha is also the chairperson of Health Home Care Nepal and current president of the Nepal Public Health Foundation. Her work focuses on geriatric health, HIV/AIDS, tuberculosis, and child health with a strong commitment to improving healthcare for vulnerable communities in Nepal. She is an honorable member of International Institute of Aging. I request you to take a seat. Take your seat. Next, we are honored to have Ms. Hira Kumari Niraula. She is the Director of Nursing and Social Security Division of Department of Health Services. She completed her nursing education at Tirubhuvani University Institute of Medicine. With years of experience in healthcare leadership, she plays a key role in managing nursing services and improving patient care. She has contributed to national research on various topics and actively participated in public health and training programs across the Nepal. Ma'am, I request you to kindly take your seat. Thank you both for being here today. We are honored to have you here with us. With that, now I request our chairs to take forward this session. Over to you, chairs.
Thank you. First of all, I would like to welcome you all for this session in aging and geriatrics in this conference, which is the very important issue nowadays in the current world. And first of all, I would like to invite our speaker, Ms. Kavita Aryal, Health Response Aging, Restoring Healthcare from Institution to Homesteading. Ms. Kavita Aryal served as a section chief at the Ministry of Health and Population, Nepal. They are responsible for geriatric health services and the health responses to gender-based violence management, contributing to national health program and policy implementation. Welcome, Kar.
Thank you. र मैले आज चाहिँ हेल्थ रेस्पोन्स टु एजिङ स्पेसली रिओरिएन्टिङ हेल्थ केयर फ्रम इन्स्टिट्युसन टु होम सेटिङको बारेमा चाहिँ आफ्नो केही भनाइहरू राख्न गइरहेको छु। हामीले पपुलेसनको कुरा गर्यो, ग्लोबल र सेयर रिजनको हामीले कुरा गर्ने हो भने पपुलेसन अब हामीले स्पेसली एजिङ पपुलेसन भन्दाखेरि 60+ पपुलेसन कुरा गर्दाखेरि 1.1 बिलियन पपुलेसन चाहिँ 60+ ग्लोबली छ भने टोटल सेयर रिजनको पपुलेसनको धनै 12.2% चाहिँ हाम्रो के छ त भन्दाखेरि एजिङ पपुलेसन छ र त्यसलाई हामीले नेपालसँग कम्पेरिजन गर्ने भने हामी 10.2% अफ टोटल पपुलेसन चाहिँ हाम्रो 60+ को पपुलेसन छ र यो पपुलेसनको माथिको हाम्रो फिगर हेर्ने हो भने जुन टोटल पपुलेसनको हेर्ने हो भने हाम्रो पपुलेसन इन्क्रिजिङ ट्रेन्डमा छ र तल अर्को फिगर हेर्ने हो भने चाहिँ हामीले पपुलेसनको अलिकति यो प्रपोर्सनलाई हामीले के लाउने हो भने यो प्रपोर्सनमा चाहिँ 3 सेगमेन्टमा हामी डिस्कस गर्न सक्छौँ र 3टा सेगमेन्टमा चाहिँ चिल्ड्रेनको पपुलेसन अहिलेको अवस्थामा चाहिँ हामीले 31.4 पपुलेसन छ भने एजिङ पपुलेसन चाहिँ 10.2 छ। तर यसको प्रोजेक्सन हेर्ने हो भने 2050 सम्म जाँदाखेरि 2051 सम्म हामीले सेन्ससको पपुलेसनको प्रोजेक्सन हेर्ने हो भने यो 27% पुग्छ भने चिल्ड्रेनको पपुलेसन चाहिँ 15% पुग्छ। र त्यो बिचको पपुलेसन जुन चाहिँ युजुअली हेल्दी पनि हुन्छ त्यो पपुलेसनको चाहिँ लगभग एभरेज उस्तै देखिन्छ। र यो विषय मैले यो किन हाइलाइट गर्न खोजेको भने यो इन्भेस्टमेन्टको रियल एलोकेसन चाहिँ जरुरी छ। अहिले हाम्रो जति पनि रिसोर्सेसहरू छ त्यो रिसोर्सेस चाहिँ बिलो 14 इयर्सको पपुलेसनमा चाहिँ हामीले धेरै इन्भेस्टमेन्टहरू गरेका छौँ, रिसोर्स एलोकेसन गरेका छौँ। तर मैले यो एलोकेसनलाई चाहिँ हामीले अबको यो प्रपोर्सनलाई हेर्ने हो अथवा यसको जुन प्याराडाइम सिफ्टलाई हेर्ने हो भने डेमोग्राफिक सिफ्टलाई हेर्ने हो भने हामीले यो रिसोर्स एलोकेसनलाई पनि हामीले रिथिङ्क गर्नुपर्छ यसरी नै भन्ने कुरालाई गर्यो। जसरी अब हामीले भन्छ नेपालको विकास भन्दा हाम्रो एजिङ चाहिँ फास्ट भइरहेको छ र 2051मा हामी 3 जना मध्ये 1 जना चाहिँ के हुन्छ त एउटा सिनियर सिटिजन हुन्छ। हामी कतिवटा 3 जना छौँ त्यतिवटा चाहिँ 1 जना चाहिँ के हुन सक्छौँ हामी सिनियर सिटिजनमा जान्छौँ भनेपछि हाम्रो लागि सोच्ने बेला चाहिँ आजै आइसकेको छ भन्न चाहन्छु। र अर्को कारण भनेको सिफ्टिङ अफ डिजिज बर्डन पनि हो। अघि हामी भर्खरै अगाडिको प्लेनरी सेसनमा पनि डिस्कस गरिसक्यौँ। हामीले एनसिडीको बर्डन हाई छ र हामीले 2019लाई नै फोकस गरेर हेर्ने हो भने 71% एनसिडी छ र त्यो एनसिडी बर्डनलाई चाहिँ अझ सेग्रिगेट गरेर हेर्ने हो भने एजिङ पपुलेसनमा त्यो के हुन्छ त फेरि 60+ हुने बित्तिकै त्यसको बर्डन चाहिँ अभियसली इन्क्रिज हुन्छ। र अन्य बर्डन जेनेटिक हेल्थसँग जोडेर अन्य बर्डनहरूलाई हेर्ने हो भने हाम्रो मल्टिमर्बिडिटी छ र मल्टिमर्बिडिटीमा पनि एजिङ यदि 60+ हुने हो भने त्यो मल्टिमर्बिडिटीको रेट पनि के हुन्छ त बढ्दै गएको छ। जस्तै 33.8 देखिन्छ हेर्दाखेरि र केही स्टडीहरूले चाहिँ अब केही स्टडीहरूले देखाएअनुसार डायबिटिज मलाइटिस पनि हाम्रो के छ त 60 इयर्स+ एबभमा चाहिँ 13.3% चाहिँ देखिन्छ। र अर्को हाइपरटेन्सन पनि नेसनल एभरेज हो भन्दा यदि हामी 60+ को पपुलेसनमा हेऱ्यो भने अभियसली त्यो बढी छ। र अर्को मेन्टल हेल्थसँग जोडेर स्पेसली डिमेन्सियालाई केही स्टडीहरूले सजेस्ट गरेको अनुसार एस्टिमेसन चाहिँ अहिले पनि नेपालमा 1,35,000 चाहिँ लिभिङ विथ डिमेन्सिया भनेर रहेको छ। र अब लिगल फ्रेमवर्कलाई हामीले हेर्ने हो भने लिगल फ्रेमवर्कमा हाम्रो के छ त भन्दाखेरि कन्स्टिट्युसन अफ नेपालदेखि लिएर हाम्रो गाइडलाइन्स हाम्रा हेल्थ पोलिसीहरूले पनि यसलाई एड्रेस गरेको पाइन्छ। र अब हेल्थ सिस्टमले हामीलाई कसरी चाहिँ यो सर्भिस डेलिभरीलाई चाहिँ मोडल गरेको छ भन्दाखेरि एउटा चाहिँ हाम्रो बेसिक हेल्थ सर्भिसमा पनि जेनेटिक सर्भिसलाई चाहिँ इन्क्लुड गरेको छ जुन चाहिँ हाम्रो जनस्वास्थ्य नियमावलीमा बेसिक हेल्थ सर्भिसभित्र हाम्रो जेनेटिकलाई स्पेसली स्क्रिनिङ, रिफर र हेल्थ प्रमोसनल एक्टिभिटिज, फिजियोथेरापी, रिहेबिलिटेसन र पोषण सेवा न्युट्रिसनको सर्भिसलाई चाहिँ के गरेको छ त भन्दाखेरि बेसिक हेल्थ सर्भिसभित्र हामीले त्यो प्याकेजमा इन्क्लुड गरेका छौँ। र अर्को हाम्रो हस्पिटल बेस्ड सर्भिसहरूलाई जुन स्पेसलाइज्ड केयरको रूपमा चाहिँ एक्सपान्ड गर्दै अहिले झन्डै 67वटा पब्लिक हस्पिटल्सहरूमा चाहिँ जेनेटिक केयर सर्भिस चाहिँ एक्सपान्ड भएको छ। र यति यो हुँदाहुँदै पनि केही च्यालेन्जेसहरू चाहिँ छन्। त्यो च्यालेन्जेसलाई हामीले दुईवटा सेक्टर्समा हामीले डिस्कस गर्ने हो भने एउटा हेल्थ सिस्टम रिलेटेड च्यालेन्जेसहरू छ र त्यो भनेको हामीले जेनेटिकसँग रिलेटेड लिमिटेड सर्भिसेस हामी सर्भिसलाई एक्सपान्सनै गर्न सकेको छैनौँ, ती वाइडली कभरेज बढाउनै सकेको छैनौँ। त्यो एउटा हाम्रो लागि च्यालेन्ज छ भने त्यो च्यालेन्जसँग अर्को जोडेर आउने भनेको चाहिँ हाम्रो वर्कफोर्स, ट्रेन्ड वर्कफोर्स। हामीले एउटै व्यक्तिलाई के छ त नियोनेट केयर पनि तिमी नै गर, एल्डरली केयर पनि तिमी नै गर भनेर हामीले लगिरहेको छौँ। स्पेसलाइज वर्कफोर्सहरूको तयार गर्ने कुराहरू हामीसँग लिमिटेड जेनेटिसियन हुनुहुन्छ अनि त्यसलाई चाहिँ हामीले फेरि के छ त भन्दाखेरि हामीले टास्क सिफ्टिङ गरेर सर्भिसलाई चाहिँ चलाइरहेका छौँ। र अर्को चाहिँ विक स्क्रिनिङ र अर्ली डिटेक्सन एनसिडीको अघिको प्रेजेन्टेसनलाई पनि हामीले प्यारालाइसिसनको प्रेजेन्सलाई लिङ्क गर्ने भने पनि अब हाम्रो त स्क्रिनिङ पनि यति एनसिडीको बर्डन बढ्दो छ कि स्क्रिनिङ प्रोग्राम हाम्रो के होस् त भन्दाखेरि हाम्रो एउटा पब्लिक हेल्थ मेजर पब्लिक हेल्थ प्रोग्राम हो नि त स्क्रिनिङ, त्यो चाहिँ हाम्रो कमजोर हुँदै गइरहेको छ। र अर्को हाम्रो कल्चरल सिस्टम जुन हाम्रो स्ट्रेन्थको रूपमा थियो त्यो कल्चरल सिस्टम जुन हाम्रो ट्रेडिसनल्ली पनि हाम्रो सेफ्टी नेटको रूपमा काम गरेको थियो त्यो पनि बिस्तारै इरोजन भइरहेको छ। हाम्रा युथहरू माइग्रेसन इन आउट माइग्रेसन छन्, चाहे त्यो ब्रेन ड्रेनको कुरा गरौँ चाहे त्यो मसल ड्रेनको कुरा गरौँ। त्यसपछि आएर ट्रान्जिसन हाम्रो जोइन्ट फ्यामिलीमा एउटा जुन हाम्रो कल्चर थियो, हिजो हाम्रो सोसल सिस्टम थियो, त्यो जोइन्ट फ्यामिलीबाट न्युक्लियरतिर चाहिँ के भइरहेको छ त ट्रान्जिसन भइरहेको छ। र सिनियर सिटिजन्स जहिले पनि चाहे त्यो फिजिकल इमोसनल सपोर्टमा चाहिँ लेफ्ट बिहाइन्ड छन् र केयर ग्याप छ किनभने फ्यामिली हेज नट एराउन्ड आवर सिनियर सिटिजन्स होइन। जब त उनीहरू एकदम मोस्ट भल्नरेबल हुन्छन् त्यो बेलामा उसको फ्यामिली उसँग साथ हुँदैन र त्यो केयर ग्याप पनि रहेको छ। र आज हामीले छलफल गऱ्यौँ भने चाहिँ अर्बन र रुरल भ्याकुम त त्यो इक्विटीको पर्सपेक्टिभबाट कुरा गर्ने हो भने अर्बन र रुरल भ्याकुम पनि छ र अर्बनमा केही हदसम्म प्राइभेट सेक्टर्सहरू एक्टिभ देखिन्छ होइन होम केयरहरू दिनको लागि र अलिकति पैसा धेरै परे पनि त्यो सर्भिस चाहिँ हामीले प्रोभिजन गर्न सकिन्छ प्राइभेट सेक्टर थ्रु पनि रुरलमा त त्यो प्राइभेट सेक्टरको एक्जिस्टेन्स पनि छैन र त्यो सर्भिस लिनलाई के छ त होम बेस्ड केयर सर्भिस लिन अथवा एजिङ पपुलेसनलाई चाहिँ जुन निड एड्रेस गर्नलाई त्यो अझ के छ त एक्सपेन्सिभ छ र यस्तो अवस्थामा चाहिँ हेल्थ सिस्टम रिओरिएन्टेसन चाहिँ चाहिन्छ टु इन्स्योर द इक्विटी अफ अर्बन पुवर र रुरल सिनियर सिटिजनलाई चाहिँ अभियसली त्यो हाम्रो रिस्ट्रक्चर चाहिँ चाहिन्छ रिओरिएन्टेसन चाहिन्छ हेल्थ सिस्टमको लागि किनभने अहिले भएको हस्पिटल केयर मोडलले के त भन्दाखेरि हाम्रो सबै निड स्पेसली मोस्ट भल्नरेबल पपुलेसन त्यो एजिङ पपुलेसन त्यो हाम्रो सिनियर सिटिजन्सहरूको निडलाई एड्रेस गर्नलाई चाहिँ यो हस्पिटल सेन्ट्रिक चाहिँ केही हदसम्म फेल पनि छ र अब हामीले के गर्न जरुरी अब लेट्स थिङ्क अबाउट द होम बेस्ड केयर हामीले चाहिँ अघि हामी छलफल योभन्दा अगाडिकै सेसनमा मैले लिङ्क गर्न चाहेँ हामीले थुप्रै हेल्थ फेसिलिटी खोलेका छौँ र त्यो हेल्थ फेसिलिटी खोल्दैमा के हाम्रा सिनियर सिटिजन चाहिँ हाम्रो सेवा लिन आउन सक्नुहुन्छ त हाम्रो प्रडक्ट उहाँसँग लान सक्छौँ त भन्ने कुराको प्रश्न छ सो द्याट त्यो प्रडक्ट्स डेलिभर गर्न अभियसली होम बेस्ड केयर चाहिन्छ होला र त्यो होम बेस्ड उसले चाहिँ किनभने किनभने हामीले अहिले त पहाडमा हेरौँ धेरै जसो जति पनि ज्येष्ठ नागरिक हुनुहुन्छ पहाड हिमालीमा हेर्नु उहाँहरूको अब पछि माइग्रेसन छैन उहाँहरू मर्न कुरिराख्नु भएको छ त्यहाँ त्यसपछि सायद उहाँको फ्यामिलीमा कोही छैन होला माइग्रेट हुने सबै मान्छे आइसक्यो भनेको मतलब उहाँहरू चाहिँ एक्लै हुनुहुन्छ र त्यो अवस्थामा हाम्रो हेल्थ फेसिलिटी त्यहाँ खोलेर के अर्थ भयो र त्यो हेल्थ फेसिलिटीको सर्भिस हामीले जबसम्म घरमा पुर्याउन सक्दैनौँ तबसम्म हामीले सिनियर सिटिजनलाई चाहिँ सर्भिस एक्सेस गराउन सक्दैनौँ सो द्याट अनि अर्को कुरा चाहिँ एउटा सिनियर सिटिजनलाई हस्पिटलाइज गर्दाखेरिको रिस्क पनि हामी घटाउन सक्छौँ र साइकोलोजिकली इम्पावरमेन्ट पनि उहाँलाई गर्न सक्छौँ र अर्को कुरा एभरेज 15देखि 20वटा ओपिडी भिजिट देखिन्छ हाम्रो बेसिक हेल्थ सर्भिसमा र त्यही हेल्थ फेसिलिटीलाई चाहिँ हामीले त्यहाँको हेल्थ वर्करलाई हामीले कम्युनिटी भिजिट अथवा होम भिजिटमा लान पनि सक्छौँ सो टु इन्स्योर द इक्विटी अफ आवर सिनियर सिटिजन वी मस्ट सिफ्ट आवर प्याराडिजम इफ क्लाइन्ट इज अनेबल टु रिच द हेल्थ फेसिलिटी सुड मस्ट रिच द आवर सिनियर सिटिजन भन्न चाहन्छु र मैले केही मोडलहरू चाहिँ हाम्रो एउटा कस्तो हुनुपर्छ त डेलिभरी अबको हेल्थ सिस्टम रिस्ट्रक्चर गर्ने हो रिडिजाइन गर्ने हो भने दुईवटा मोडल चाहिँ जस्तो अब बेसिक हेल्थ सर्भिस र हस्पिटल केही हदसम्म हामीले स्टार्ट पनि गरिसकेको छौँ र होम बेस्ड केयर र अलिकति लङ टर्म केयरको कुराहरू चाहिँ हामीले अहिले अझै हामी ग्यापमा छौँ र अहिले अब होम बेस्ड केयरमा पनि स्पेसल्ली केही सर्भिसहरू चाहिँ हामी होम बेस्डमा जस्तै बेसिक हेल्थ सर्भिसको केही कम्पोनेन्ट्सहरू होइन स्क्रिनिङको कुराहरूदेखि लिएर फ्राइलिटी एसेसमेन्टका कुराहरू चाहिँ हामी होम बेस्डमा पनि केही हदसम्म लान सक्छौँ र त्यसपछिको रिफरल्सहरू केही डिजिटल अप्लायन्सेसहरू युज गरेर डिजिटल डिभाइसेसहरू युज गरेर मोनिटरिङहरू गर्न सक्छौँ होम बेस्डमा पनि होइन र त्यसपछि आएर बेसिक हेल्थ सर्भिस हुँदै हाम्रा स्ट्रक्चर अब हस्पिटल केयरसम्म हाम्रो स्पेसलाइज फेलोसिपहरू स्टार्ट गरिरहेछौँ होइन त्यहाँ चाहिँ हामीले स्पेसलाइज एज केयर डक्टर्स नर्सेसहरू चाहिँ हामीले राख्न सक्छौँ र केही हदसम्म कोसिस पनि भइरहेछ र अर्को भनेको लङ टर्म केयर युनिट्सहरू हाम्रो छैन जुन चाहिँ अस्पतालमा यदि हामी लङ टर्म केयरहरू चाहिँ इस्टाब्लिस गर्ने हो भने अस्पतालको बर्डन पनि घटाउन सक्छौँ र त्यो प्यालेटिभ केयरको लागि हुनसक्छ होइन अथवा अन्य रिहेबिलिटेसन सर्भिसको लागि हामीले चाहिँ लङ टर्म केयर युनिट्सहरू अथवा लङ टर्म केयर इन्स्टिट्युसनहरू पनि हामीले अब सोच्नुपर्छ यो दुईवटा चाहिँ हाम्रो अहिले हेल्थ सिस्टममा ग्याप छ र यसलाई हामीले रिडिजाइन गर्नुपर्छ भन्ने हिसाबले चाहिँ मैले यहाँ हजुरहरूलाई प्रस्तुत गर्न खोजेको हस् थ्याङ्क यू मेरो प्रेजेन्टेसन यति नै होस्
Thank you, Kavita madam. I would like to invite next speaker, Sandhya Khatri. The topic of her presentation is assessing medication adherence, risk level and usage pattern among the elderly residents in selected care home across sectional study. Sandhya Khatri is the master student in pharmacy at KU, focusing on the medication use pattern and adherence risk level in elderly care home. Her research aimed to enhance the quality of care for the elderly through the safe prescribing practice and effective medication management. Hand over to Ms. Sandhya Khatri.
Warm wish and good afternoon to all the guests. All the guests and the chairs present here. Since ma'am le मेरो introduction दिइसक्नु भयो म directly डाइरेक्टली चाहिँ मेरो टपिकमा इन्टर गर्न चाहन्छु. मेरो रिसर्चको टपिक छ असेसिङ मेडिकेसन अडेरेन्स रिस्क लेभल एन्ड युजेस प्याटर्न एमङ elderly residents in selected care homes. It's a cross-sectional study and it's being supervised by my professors Durga Bista, Rojina Kojusresta, and we have external supervisor and medication safety expert Ramesh Sharma sir. Talking about the background, we all know that aging population is increasing rapidly, and in case of Nepal too. With the increase in age, they are suffering from multiple conditions like chronic conditions, which are diabetes, cardiovascular disease, and arthritis. And these multiple medication use leads to polypharmacy, which we term as the use of 5 or more medications. It is called polypharmacy, and due to the use of multiple medication, it can lead to use of potentially inappropriate medications and also the risk of non-adherence. In context of Nepal and talking about the study gap, there is about 2 million elderly population, which is increasing rapidly, which covers about 10% of the total population, according to the current census. And also, the concept of elderly home is relatively new in context of Nepal. Internationally, the elderly homes are divided into nursing home, care home, and shelter home based on the healthcare service and the facility they provide. In case of Nepal, the terms are used synonymously. And there are about 70 elderly residential homes where with one governmental one, there are around 1500 residents reside. And in this setting, the medication adherence risk and also the medication use pattern is not well studied according to the literature we have. The general objective of this study is to assess medication adherence risk level and uses pattern among elderly residents residing in the selected care homes. And the specific objectives are to assess the pattern of medication use, specially focused on the prescription, frequency of prescription and types of medication use. And the second is to assess the adherence risk level. And we also analyze the potentially inappropriate medication. Talking about the methodology, we used a cross-sectional study design where talking about the study site and sample size, we approached about 16 elderly homes, which among them 6 provided with the approval, in which there is one governmental elderly homes. And purposive sampling was done in this case. The total sample size was 103. We included those samples which fall under the age criteria, that is 60 plus. Those were residing in elderly homes and who were willing to provide the consent for the study. We excluded those who did not fall on the age criteria and also having acute problems and hospitalized during the study. Talking about the research instrument for medication use pattern, we reviewed the medical record that they had in the institution. For adherence risk level, we used medication safety alert tool for elderly, which is included in a geriatric pharmacy protocol of Malaysia, and we adopted and validated it. For socio-demographic data, we used a validated performa. For potentially inappropriate medication, we use Bayes criteria. And for the data analysis, we used SPSS, Excel, and also calculated percentage, frequencies, and association using chi-square test. Talking about the result, in case of social demographic data, the age that we encountered during the age group is listed in the table. And the education was more primary and lower level, and the least were having the degree of higher education. Talking about the sorry, functional assessment, there were more having hearing issues and visual issues. Most of the disease was hypertension, that is 29%, gastrointestinal disease 14%, arthritis 13%, and respiratory disease 13%. Since there is more hypertensive patient, the most used drug was antihypertensive. Mm, and the untreated conditions were arthritis, bone disease, and mainly psoriasis. There was high prevalence of polypharmacy too. And in case of medication adherence risk level, 62.7% were low risk, 36.1% were medium risk, and 1.2% were high risk. And the socio-demographic data did not show any association with the medication adherence risk level. And the most used potentially inappropriate medications were proton pump inhibitor, NSAIDs, and antipsychotic medications as shown in the pie chart. Let's move on with the discussion part. Since hypertension was most prevalent, antihypertensive disease was medication was most used. There were high prevalence of polypharmacy and potentially inappropriate medications, which indicate that there is the system of irrational medication prescribing, and there lacks the proper medication review system. There is some system level gap too. In elderly care homes, there lacks proper record management system of medications, which indicates that there is lack of continuity of care in this setting, which can further cause medication error and inappropriate medication therapy. In case of adherence insight, we did not find the adherence risk level was low to moderate, that is it was satisfactory level. It might be due to the institutional support or presence of at least one healthcare supporter or healthcare professional in those settings. The case of untreated medical condition shows that there is no proper comprehensive patient care, that is in detailed patient care is lacking in this sector. Only the medications are directed towards symptomatic relief rather than root cause analysis. Since I have already covered maximum part of conclusion in result and discussion session, I want to focus on what we need to do. We need to more focus on rational prescribing system, proper medication review, and proper healthcare support system in those elderly care settings. The takeaway message is that we have to make policy more focused to medication management in geriatric, and also the care homes should be properly supervised by the concerned authorities regarding the medication use, irrational prescribing practices, and the healthcare management support system. And I would like to express my gratitude to my supervisors who helped me and guided me throughout the thesis and this research. I would like to thank Kathmandu University for academic support. I would like to thank all the participants and the institutions who provided me with the data. I would like to thank my partner for helping me to find about the subject matter and continuous support. I would like to thank all the people who directly and indirectly helped me during the research. These are the references and this is my bio. Thank you.
Thank you, Sandhya Khatri, for a very good presentation regarding the medication adherence risk level among the geriatrics, which is the very important topic regarding polypharmacy, regarding geriatric people. Now, I would like to invite Rohit Agrawal. He is going to present the predictors of medication-related quality of life among older adults with chronic illness in Nepal. Insights from multimodal predictive analytics. Rohit Agarwal holds a Master of Pharmacy in Clinical Pharmacy from Sri College of Technology, Purvanchal University, Bharatpur, Chittagong. His research interests include drug use among geriatric patients, medication-related quality of life, and the quality use of medication. He possesses skill in systematic review, meta-analysis, SPSS, R, machine learning, and predictive analytics. Thank you.
Thank you, Chair. Respected Chair and researchers, I am very excited to share my research on predictors of medication-related quality of life among older adults with chronic illness in Nepal, where we have moved beyond traditional statistics towards predictive analytics using multimodal approach. Aging is a natural process accompanied by physiological and pathological changes that leads to multimorbidity and necessitates pharmacotherapy. Pharmacotherapy in older adults are accompanied by positive and negative therapeutic, economical, and humanistic outcomes. Humanistic outcomes are less resourced but are essential to evaluate the holistic success of pharmacotherapy, especially through patient-centered approach. One of the humanistic outcome is medication-related quality of life, which is a multidimensional construct measuring the treatment burden of the patients. In case of Nepal, we are seeing a rapid demographic shift in older adult population, resulting in multimorbidity, polypharmacy, and drug-related problems. The health-related quality of life measures fails to capture the treatment burden, while the medication-related quality of life, by capturing the medication-related burden, they also capture psychological impact, treatment convenience, patient-provider relationship, ultimately leading to providing information on targeted interventions and to support policy planning. So in this study, we tried to evaluate the medication-related quality of life among older adults using a prompt QOL questionnaire, and we also evaluated the predictors of medication-related quality of life using a multimodal predictive analytics. This was a cross-sectional study that was conducted in the outpatient pharmacy of tertiary care government hospital, where 310 older patients aged 65 years or above taking medications for at least last 3 months and diagnosed with at least one chronic illness were included in the study. A paper-based structured questionnaire was used, which consisted of translated and validated Nepali prompt QOL questionnaire along with 14 predictor features. The sample size of 310 was achieved through a rule of thumb which says 20 observations per feature. The ethical approval was taken from Sri College of Technology Institutional Review Committee. Written informed consent were taken from each participants, and permissions from developer or tools were also taken. Now the main outcome, the medication-related quality of life, was measured using prompt QOL questionnaire, which was developed by Saktong et al. It consists of total 43 items divided into 9 domains, from medication and disease information to psychological impact, convenience, accessibility, availability, and therapeutic relationship. The total prompt QOL score was measured using this formula, which ranged from 0 to 100. Higher prompt QOL score implies higher medication-related quality of life. To predict the medication-related quality of life through prompt QOL score, 14 predictor features were identified prior to study, which included sociodemographic features, clinical features, and pharmacotherapeutic features. These features were measured using standard tools like Beers criteria, Eurocol, and Carlson Comorbidity Index, among others. Now this is where we moved beyond the traditional statistics. The data obtained on 310 older adults after performing descriptive and bibliometric analysis. A predictive analysis was done using 4 models: ordinary least square regression, elastic net regression, XGBoost regression, and random forest regression. In the latter 3 models, we performed a 80-20 split in the data set, followed by cross validation, and ultimately the final model obtained was evaluated using performance metrics like R square, RMSE, MAE. The black box nature of these AI models were finally interpreted using the SARP interpretation method. All the analyses were performed in R. Moving on to the results, our participants were mostly married. In case of education and gender, we can see an equal split among the categories. Hypertension was found to be the most prevalent chronic illness, followed by diabetes mellitus and COPD, and almost half of the patients were found to be have encountered with an potentially inappropriate medication. Our participants had a median age of 72 years, were diagnosed with 2 chronic conditions and prescribed with 5 medications on an average. The adherence score was found to be high with an average of 33. Now the total prompt QL score. The total prompt QL score was found to be 64 out of 100, which indicates only a moderate medication related quality of life in older patients of Nepal. This moderate score was primarily influenced by the medication and disease information score, which is only 33.3. This indicates that although the patients were physically taking their medications properly, but they lack information. They were unaware about the medication and disease related informations. The initial biometric analysis shows that marital status, living status, primary diagnosis were significant factors affecting the prompt QL scores. Along with that, chronic conditions, CCI score, equality score, number of medications, adherence score, and medication duration were also significant factors. But we moved beyond this biometric analysis and performed predictive analysis, where the 4 models were compared along with these metrics. Among the 4 models, XGBoost model or non-linear supervised model was found to be the superior model, showing 60% R square value and the least MAE RMCE values. To determine the drivers behind these predictions, the SAP analysis was used to rank the various 14 features. While ranking these features, we found that pharmacotherapeutic variables like adherence score, medication duration, number of medications were the top predictors of medication related quality of life, while sociodemographic variables like education, ethnicity had only low predictive power. This forest plot was the result of the ordinary least square regression, where we can see the magnitude and direction of the linear relationship between the predators and medication related quality of life, where the equality score and adherence score were found to be the most significant, strongest positive predictors, while number of medications and number of chronic conditions were found to be some of the negative predictors of medication related quality of life. But previously we found that the XGBoost model was the superior model, which suggests that there exists a non-linear relationship between the predictors and medication related quality of life. So to evaluate that non-linear variables, we use the SAP values. In these plots, the SAP values were plotted against the predator values to visualize the non-linear relationship between the predators and medication related quality of life. In this, if you see at the upper middle plot, the adherence score plot is a somewhat S-shaped plot. Between score 28 and 32, we can see exponential increase in medication related quality of life. This indicates that our interventions should target these patient groups. Simultaneously, if we see at number of medications plot, it is a somewhat L-shaped plot, where the medication related quality of life is decreasing rapidly from 1 to 7 number of medications, but after 10 medications there is almost a plateau. This indicates that suppose if a patient is on 13 number of medications, if we try to reduce it to 10 or 11, then there is not a significant increase in medication related quality of life. But however, if we reduce a number of drugs of patient from 8 to 6, then the improve in medication related quality of life is quite significant. Similarly, if we see in the medication duration plot, we can see a V-shaped curve, a valley of burden between 5 to 15 years of duration. During this duration, the medication related quality of life is used. So our interventions will target patients within this valley. So from these results, what we can say is that there is a moderate medication related quality of life in older adults. There is a poor medication knowledge and need for targeted patient education. The XGBoost model, a supervised nonlinear model, is found to be the strongest predictor analysis, where the pharmacotherapeutic variables were found to be the strongest predictors. And most importantly, the nonlinear relationships identified, like adherence therapeutic window, saturation of polypharmacy burden, valley burden of medication duration. These kind of relationships are critical to obtain maximum benefit of interventions, especially in resource limited settings like Nepal. So the insight from this study is that medication related quality of life declines at a predictable thresholds. We should act to target on adherence, duration and polypharmacy thresholds to prevent treatment failures. Ultimately, we suggest to move beyond counting medications and focus on identifying and acting on risk windows. Thank you.
Thank you, Rohit Agrawal. Then I would like to invite Dr. Rekha Timalsina. The topic of the presentation is Development and Psychometric Evaluation of the Self-Compassion Scale for Nepalese Older Adult with the Chronic Disease, a mixed method sequential exploratory research design. Dr. Rekha Timalsina is an associate professor at the School of Nursing and Midwifery, Patan Academy of Health Science, and a founding member of the National Institute of Aging and Health, Kathmandu, Nepal. She holds a PhD in nursing science from the Prince of Songkla University, Thailand, along with the master degree in nursing, psychology, sociology from the Tribhuvan University. Her work focus on advancing nursing education, compassionate care, and geriatric health, with multiple publication and prestigious academic award. Over to you, ma'am.
Thank you so much, dear chairs. First of all, good afternoon, everyone. It's me, Dr. Rekha. Today, I'm here to present our research findings on development and psychometric evaluation of state self-compassion skills among older adults with chronic diseases. This is our team. These are the outlines of my presentations. Now moving towards the background, as we know that global geriatric population is increasing in trend, along with rising burden of non-communicable diseases. So in this context, self-compassion might be a positive psychological construct and a key for happy life that promotes the psychological well-being, psychological healthy aging, as well as coping abilities. However, self-compassion related tools among older adults with chronic disease have not been developed yet, and none of the tools have been tested among older adults. Thus, this study aimed to identify the suitable components of the state self-compassion and to develop a scale of self-compassion as well as evaluate its psychometric properties. So we adopted sequential exploratory mixed method research designs among older adults with chronic diseases at Kathmandu metropolitan city, and people whose aged 60 years and above residing at KMC and at least own chronic diseases were the inclusion criteria, and the older adults who had severe psychiatric morbidities as well as cognitive problems were the exclusion criteria. We adopted at 2 phases of with 8 steps of psychometric evaluations of instruments followed by DeValis 2017. In phase 1, we developed the scales related to self-compassion scales followed through content domain determinations to determine the instrument format. Then we moved to second phase, psychometric evaluations of state self-compassion scales. We moved through content validations by our experts as well as moved through scale length optimizations as we discussed the second phase of our instrument development in later. In first phase, we conducted qualitative studies among 15 older adults who had been selected purposively, and in second phase we adopted convenience as well as quota samplings, and sample ranged from 42 to 500 in different steps of psychometric evaluation of skill development. By adopting all the ethical procedures and taking approval from Nepal Health Research Council, our research assistants as well as the researcher collected data through face-to-face interviews. And in first phases, we used in-depth interview guide, as well as in second phase, we used newly developed state self-compassion scales along with 13 items social desirability scale. Data were analyzed through exploratory factor analysis, confirmatory factor analysis, contrast group approach, as well as reliability testing and assessment of floor as well as ceiling effect, along with correlation of social desirability scales with newly developed state self-compassion scale. Now moving towards the result, I will discuss the findings of phase 2 of psychometric evaluations of our newly developed state self-compassion scale. In phase 2 of psychometric evaluations, we followed through content validations by our experts, and we requested 7 experts to validate our content of 78 items of newly developed state self-compassion scales. Based on the ratings of our experts, we calculated the ICVI, SCVI, as well as CVR, and all the indices of these content validations were found acceptable. And then we moved to face validation procedures, and we requested 10 experts, and we calculated IFVI as well as SFVI, and all the indices of face validity were found acceptable. Then we reduced the items from 78 to 26 items based on the content as well as face validation procedure. After content and face validations, we requested our experts. We requested our experts for face validations. Along with, we got responses from our older adults. We included 42 older adults, and then based on their responses, we calculated the reliability coefficients, and all the indices were found also acceptable. And we reduced 22 items, and we developed draft 3 versions of state self-compassion scale. Then we moved to step 6 of field test of our instruments, and we employed 500 samples who were selected through convenient sampling approach, and then we collected data from them, and we splitted 50 by 50 approach to conduct confirmatory as well as exploratory factor analysis, and 250 for EFA and 250 for CFA. This table shows that majority of older adults belong to 65 to 74 years of age group, male, married, as well as illiterate. And before performing exploratory factor analysis, we tested for the sample adequacy for EFA, and the indices found acceptable. And then we moved to analyze our factor extractions, and factor extraction with principal axis factoring as well as Promax rotation methods. We found that 16 items of state self-compassion scales were valid, and factor loadings range from 0.4 to 0.88. And we, based on the exploratory factor analysis, we reduced our 22 items into 16 items, and we removed 4 items, 6 items based on low factor loading. And this is the findings of confirmatory factor analysis. In this test, we found that our instrument, state self-compassion instrument, is valid, and factor loadings range from 0.32 to 0.78 along with acceptable reliability coefficients and corrected item total correlation. And we reduced our 16 items into 15 items based on the confirmatory factor analysis. And all the indices, absolute fit indices as well as incremental fit indices, were found acceptable, and this reflects that our instrument is valid among older adults. And the subdomains of state self-compassion scales were also correlated with our overall scale of state self-compassion scale. And regarding the social desirability bias and very weak correlations among social desirability scales as well as state self-compassion scales, that means that our older adults express their genuine feelings towards our scales. And no floor as well as ceiling effects were observed for overall scale of state self-compassion scales, but for individual items, we see floor as well as ceiling effects. And again, we moved to the field and we collected data with our 15 items of state self-compassion scales, and we calculated the different statistics using the t-test as well as other tests. And based on the t-test findings, we can see that our instrument distinguishes the self-compassion scales based on marital status, literacy status, as well as having children. And then we optimize our scale into 15 items state self-compassion scales. And in our conclusion, our newly developed 15 items state self-compassion scale is valid in terms of its content, face validations, as well as construct validity. This instrument is reliable, have minimal bias, and sensitive to identify the self-compassion among older adults. And take-home message is this instrument is useful for nurses as well as other healthcare professionals, but this skills needs to be revalidated into diverse older adult populations to enhance its generalizability and to overcome our limitations. Sorry. This is our acknowledgement slide and the sample questions. How often do you perform activities that could harm your health? How often do you follow your prescribed medication schedule? Thank you so much.
Thank you. Now I would like to invite another speaker, Kritika Shrestha. She's going to speak the healthcare utilization and its associated factors and healthcare expenditure among elderly population of Banepa municipality. Ms. Shrestha holds a MPH degree from BP Koirala Institute of Health Science and currently working as research coordinator at Tulikhel Hospital with over 5 years of experience in clinical practice, academia, and community-based health program. She is dedicated public health researcher focusing on geriatric health and health economics and committed to improving health equity and financial protection for the elderly through data-driven policy recommendation. Welcome you.
Thank you. Imagine being 70 years old, living alone with multimorbidity and wanting to see a doctor but couldn't. Not because there were no health facilities nearby, but because there was no one for you to take care of to lead you to the health facilities. And this is not hypothetical. These are the lived experiences of elderly people of Banepa municipality and probably across many communities across in Nepal. Namaste and good afternoon, everyone. Esteemed chairs, participants, and delegates. I am Kritika Shrestha, and today I'll be presenting on the findings of my study, Healthcare Utilization and its Associated Factors and Healthcare Expenditure among Elderly Population of Banepa Municipality. So walking you to the background, which most of the former participants had already talked about, but the Senior Citizen Acts of Nepal 2063 defines the sector senior citizen as people who are 60 and above. A rapidly aging population, that is, the Nepal's elderly population is in rapid rise. That rose from 5.8% in 1991 to 8.1% in 2011, surpassing the national growth. Globally, by 2050, 79% of the world's 2 billion elderly population is expected to reside in developing regions like Nepal. And in Nepal, 6.8% of the population are elderly within Kabri Palanchok district. The number is 7.4. Banepa municipality alone has over 1,800 elderly population. So why needed to study in vulnerable population like elderly? Because aging is an independent risk factor and have high health vulnerabilities, vulnerable with regards to both over and underutilization of health services, and also bearing economic costs. So we asked the question regarding the health service utilization of the elderly people of the last within the 12 months of period, and regarding healthcare expenditure, the latest visits, questions about the latest visit were asked. So this brings us to the objective of the study, which is the utilization of healthcare services, its facilitators and barriers, and to estimate out-of-pocket expenditure on healthcare. So coming to the methodology, this is a cross-sectional study with mixed method design in Banepa municipality, which was conducted from September 2020 to April of 2021. And all the elderly participants over 60 years of age residing in Banepa municipality for at least 1 year were included, and those who consent were included in the study. This was a multi-stage random sampling where the first stage we selected 7 out of 14 wards, and in the second 150 households were selected, and in the third stage the eligible elderly population participant was selected. Sample size was 150 based on the power prevalence calculation from previous study, and 3 focus group discussions were also conducted to understand the lived experiences of the elderly population behind the numbers. So coming to the results, the socio-demographic highlight shows that 70.2 years was the average years of the elderly population, and the majority were female, and Newar being the majority ethnicity. And 68% have no current personal income, and the 32% with current income had median annual income of around $1,500 US. Coming to the health status and chronic illness spectrum, 47.3% reported their status at good health, and 62% suffer from chronic illnesses, hypertension being the leading cause. The figure 1 shows that 56.7% of the participants had utilized healthcare in past 12 months, and among those who utilized, 47% at preference of private hospitals and clinics over other facilities, and government hospitals sitting at 8.1. And among those users, around 86% were satisfied with the services received. So 25% of the participants had some kind of barriers. The barriers were no companion and fear of COVID, which was twice as restrictive than the financial barriers. This figure shows the health insurance awareness of the participants, where 48.7% were aware of the health insurance. And of all the participants, 30.7% had the membership card, and among them around 67% utilized national health insurance, and among those who utilized, around 84% were satisfied with the health insurance program. This figure shows that a staggering over 90% of the participants were unaware about geriatric health card insurance scheme. And in this slide, I want you to sit for a moment in this slide where none of the participants, I repeat, none of the participants were aware about the Bipin Nagarik course. In table 1, this shows the agriculture, previous occupation as agriculture, shops and markets, health concern, chronic illnesses, and awareness of national health insurance had significantly higher odds of healthcare utilization. In the binary logistic regression, agriculture, chronic disease, having more than one chronic disease, and barriers of health utilization, where there were no barriers, were significant predictors of healthcare utilization, with chronic disease being the strongest one. Coming to the health expenditure, the median cost were around 530 Nepali rupees. 68% of elderly rely on family members to pay for healthcare, and participants without a partner were more likely to have more health expenditure than those without a partner. Here I'm listing the qualitative component things for your reference. They were health problems faced by elderly, relationship dynamics with family and friends, families visited during health problems, facilities visited during health problems, healthcare providers, senior security, social security schemes, barriers of health utilization, expectation from government. So I'd like to toss briefly on discussion, which was not compulsory. The healthcare utilization and the health care expenditure was slightly lower in my study compared to other studies across the nation. However, information gap, there was still an information gap that shows there was low awareness about the geriatric schemes or other health security schemes which were inconsistent with other studies. So coming to the conclusion, only 56.8% of the elderly utilize health services with a heavy reliance on private healthcare facilities. Major barriers were high out-of-pocket expenditure and social barriers like lack of companion. A staggering 0% awareness of Bipina Nagarikos and over 90% unawareness of health geriatric cards highlight a massive failure in the health communication. Similarly, 68% are financially dependent on children. Those without partners face significantly higher healthcare costs. So here's the takeaway messages which I aligned with National Health Sector Strategic Plan 2023 to 2030 goals of health equity and quality. The first one is we should scale up awareness of social health insurance and geriatric schemes through local wards enrollment drivers. And hospitals should establish dedicated geriatric wards or clinics to provide elderly-friendly one-stop services for the geriatric population. Similarly, Nepal should now start focusing on strengthening the public health system. I cannot emphasize this enough, to reduce the catastrophic out of expenditure and to reduce dependency on private sectors. And similarly, companion programs at the local level is necessary. So I'd like to, I'm deeply indebted to my guides and co-guides and the participants of my study. Here are my reference, and that's me. And before leaving, I want to say something. We our elderly build this nation, and we should focus more on how we reach the elderly at where they are, rather than where they are reaching to struggle. Thank you.
Thank you for all the participant speakers presenting the different aspects of health in relation to geriatrics, from the health response to aging, for regarding the medication adherence and predictors of the medication with quality of life, and regarding psychomotor eval self-compassion scale, and also the healthcare utilizations. It has been covered all the aspects of the geriatric health and in the utilization of the healthcare and all the aspects. Now I would like to invite the few questions from participants.
Thank you so much. So, hello everyone. I'm Sadiq and I'm a public health student in Nepalese Army College. And I had a question for Sandhya Khatri. I wanted to know, you had mentioned that there was one government and 70 private care homes. And I just wanted to know what's the distribution pattern in the 7 provinces in our country. And do you find any mismatch between the prescribed medications and the actual uses patterns between the residents of the care home? Thank you.
Answer गर्दै पनि हुन्छ.
त्यो जुन तपाईँले डिस्ट्रिब्युसन बारेमा क्वेसन गर्नुभयो होइन, मेरो चाहिँ सिन्स यो एकाडेमिक फुलफिलमेन्टको लागि थियो, मैले चाहिँ मोर फोकस मेरो चाहिँ भ्यालीमा भएको मात्रै गरेको थिएँ. अनि टोटल चाहिँ भ्यालीको कन्टेक्स्टमा 21 छ भने एउटा मात्रै गभर्मेन्टल छ.
We will take the another 2 questions, then we will stop.
हस्, धन्यवाद. मेरो लास्ट प्रेजेन्टरलाई क्वेसन थियो, हाम्रो कृतिकाजीलाई. एउटा राम्रो रिसर्च गर्नुभएको छ. यहाँ चाहिँ नि भोलिन्टियर बेस्ड एउटा क्याम्पेनको कुरा गर्नुभएको छ कि, भोलिन्टियर बेस्ड क्याम्पेन. अलिकति त्यसलाई क्लियर पारिदिनु हुन्थ्यो कि भनेर हो.
Hello. Thank you for the question, sir. So the last the volunteer based campaign मा चाहिँ जस्तै कतिजना एल्डरली पपुलेसनहरूलाई चाहिँ मेन स्ट्रगल चाहिँ अहिले चाहिँ के भइरहेको छ भन्दा फाइनेन्सियल भन्दा पनि मेरो स्टडीले आयो नि त, फाइनेन्सियल भन्दा पनि उहाँहरूलाई चाहिँ कसरी लगिदिने मान्छे छैन. त्यस कारणले गर्दाखेरि चाहिँ कुनै पनि अब लोकल वार्ड्सतिर चाहिँ कुनै त्यस्तो क्याम्पेन रन गर्यो भने, अदरवाइज कुनै पनि हस्पिटलले नै कुनैले पनि एल्डरली पपुलेसन आइसकेपछि चाहिँ सर्टेन भोलिन्टियर्सहरू राखेर, इट मे बी स्टुडेन्ट अर इट मे बी लाइक इन्टर्न्स वेबर, कोही भोलिन्टियर्सहरू राखेर चाहिँ उहाँहरूलाई चाहिँ नेभिगेट गरिदिनु भयो भने चाहिँ त्यसले गर्दाखेरि चाहिँ धेरै नै उहाँहरूलाई चाहिँ सुलभ हुन्छ जस्तो चाहिँ मलाई लाग्छ। त्यस कारणले गर्दाखेरि चाहिँ त्यो हाम्रो नेपाल हेल्थ सेक्टर स्ट्राटेजिक प्लानमा को उसमा पनि आएको हुनाले कारणले गर्दाखेरि चाहिँ मैले चाहिँ त्यस्तो क्याम्पेन्सहरू होल्ड गर्यो राखिदिउँ भने चाहिँ एलएलडी पपुलेसनलाई चाहिँ धेरै सहज हुन्छ भन्ने कुराले चाहिँ राखेको छ। आई होप आई आन्सर यु क्वेसन सर।
लास्ट क्वेसन।
नमस्ते सबैजनामा, म अंशु ढकाल रिसर्चरको रूपमा कार्यरत छु। मेरो क्वेसन पनि कृतिका श्रेष्ठ म्यामलाई नै छ। एकदमै इन्ट्रेस्टिङ फाइन्डिङ्सहरू देखेँ होइन, विपन्न नागरिकको बारेमा 100%लाई थाहा नभएको जस्तो फाइन्डिङ्सहरू इन्ट्रेस्टिङ लाग्यो। त्यसमा टुल चाहिँ के युज गर्नुभएको थियो भन्ने कुरा चाहिँ मैले मिस गरेँ हो कि त्यो चाहिँ सोध्न चाहेँ म्यामलाई। बस थ्याङ्क यू।
मैले चाहिँ मेन क्वेसनको लागि चाहिँ सेजको टुल्सहरू युज गरेको थिएँ। अनि अरू यो चाहिँ हेल्थ इन्सुरेन्सको कुरा चाहिँ मैले अरू लिटरेचरहरू जुन प्रिभियस स्टडिजहरूबाट गरेको लिटरेचरहरूबाट चाहिँ क्वेसन्स लिएको थिएँ। अनि त्यसमा चाहिँ आउट अफ 150 पार्टिसिपेन्ट्स नन ह्याड अवेरनेस अबाउट विपन्न नागरिक कोर्स। थ्याङ्क यू।
Now we'll stop taking the questions. First of all, I would like to thanks for all the speakers and highlighting the health response to aging. Regarding the first presenters, we all know that though the percentage of the elderly population is increasing, and that there is in compared to number of child and women, it is decreasing, but still the number of, if you see the number, it is going to increase. That looking at the trend, now it has focused that all the resources for the health response needs to be focused for the geriatric people. Then only we can see how we can train, we can shape our healthcare response and healthcare system for the coming years. Then only the steps we have taken will be very much fruitful to coverage and all. Otherwise, there won't be any, as you say in the itself, now also the healthcare utilization is very low. From the last presentation, we can see the healthcare utilization is very low, and there is no awareness among the geriatrics regarding the health insurance and all the systems. And if you didn't focus now for the geriatric health and all, later on what will happen, you can imagine. There won't be anybody in the home to give the service. There won't be anybody, anything in home to take the drugs also. That's why now the government, our healthcare system has to look into that scenario. And she has also explained that now the system, healthcare system needs to focus in the home care. It needs to be the home care system. It has to focus in the home care system, and based on that, how the long-term care and the hospital care at basic sense needs to be reframed. All those she has been shown that. And we all know from the last conference, and we all know the prevention is better than care. All the preventive activities we can do in the home. Our elders who build the house their homes, why don't they have a rights to stay in their home, and they have a rights to have a care in their home? That will make the happy for the elderly, that will make the happy for family. And if we make the things in clear picture, home care design in such a way that complete care in the home, focusing in the preventive aspect, then only all the complete care we can give there, and the burden of the health system we can decrease in the health hospitals and all. We can focus in those part. So we are reframing focusing the home care service and the on the other thing. And one of the on my experience from the working from the policy level to the implementation level, from all the 15 years, I can see that geriatric healthcare service is the one of the examples which is built on from the policy level to the implementation level. Now Hira ma'am will describe how our policy is there and how much the services we have developed in our country, that will be highlighted. In the same way, another presenter is not only here polypharmacy. Polypharmacy is the problem for not only geriatric, other groups of also, but mostly the problem for the geriatrics. It is not here, it is a worldwide. Polypharmacy, that is, we all know, all the geriatric people say, why I have to eat so many medicine? I don't, and another things is not, there is no people in the home to guide them to give the drugs also, and they have such a problem to get the medicine on time. And that's why the polypharmacy is the very big problem. And but still, now another presenter, he has presented very well the predictors for the quality of life in relation to medicine. Now, this shows that we need the geriatric focused medication management. which is very much important, and we all know that this has been focused. I accept that it has to focus in the curriculum of the MBBS, and because we all know that there are different comorbidities in the geriatrics, and lots of medicine needs to be given, but the management for the geriatric medication is very important, and it needs to focus, it needs to train the doctors through the curriculum. And I hope that it has been taken care of. Now the MBBS curriculum is redeveloping and by the MEC, and I hope that this has been taken care in that aspect. And also the regarding the not only the polypharmacy and all, we have to see that we need the medication education. What he has highlighted, that is the very importance. They know they are taking the medication, but they don't have an education on that. That is the mostly lacking point, and we all have to focus in the medication education for the elderly people. That also maybe decrease the risk factors among the geriatrics and also the risk level. And another one, healthcare utilizations, which last presentation is very good. It has utilized. That's why for the geriatric healthcare services, when we design, we all have to see the 3A: affordability, availability, and accessibility. If everything is there, if there is no access, nothing is there. That's why we all have to, our healthcare system needs to focus on those things, and the research also showing all those things. For the utilization of the healthcare service, we have to see all these aspects. Saying this, I would like to thanks all the presenters, and also I would like to thanks all the participation for the active participation in this. Saying this, I would like to hand over.
थ्याङ्क यू लोचना म्याडम. लोचना म्याडमले मोस्ट अफ चाहिँ समराइज गरिसक्नु भएको छ. पाँचैजना प्रेजेन्टरले चाहिँ एकदम कम्प्रिहेन्सिभ इन्साइटफुल प्रेजेन्टेसन गर्नुभएकोमा सबैलाई धन्यवाद र बधाई पनि छ. अब म्याडमले प्रायः सबै भनिसक्नुभयो. विभिन्न अध्ययनले के देखायो त भन्दाखेरि अब कम्पेनियन कोही पनि छैनन् इल्डरलीको. सबै भनौँ न हाम्रो छोराछोरीहरू बुढाबुढी मान्छेलाई हेर्नको लागि नेपालको कन्टेक्समा सबै बाहिर भएको कारणले बुढाबुढी मात्रै छन् भन्ने चाहिँ देखिसकेको अवस्था छ र केयरमा लैजानको लागि उहाँहरूलाई चाहिँ गाह्रो छ भन्ने छ. र अर्को कविता म्याडमले प्रेजेन्टेसन गरिसक्नु भएको छ कि हस्पिटलमा गएर सेवा लिनको लागि पनि गाह्रो छ भन्ने. त्यसैले अब रिओरिएन्टेसनका कुरा, होम बेसमा हामीले सेवा दिनुपर्छ कि भन्ने कुरा आइसकेको छ. यसै सन्दर्भमा हाम्रै महाशाखामा पनि जेरियाटिक हेर्ने एउटा शाखा छ, जस अन्तर्गत हामीले अब स्क्रिनिङ टुलको चाहिँ विकास गर्न खोजिरहेछौँ यसमा, जसमा चाहिँ WHO को आइकोपका कन्टेन्ट राख्ने, त्यस्तै गरिकन पोली फार्मेसी छ कि छैन स्क्रिनिङ गर्ने बेलामा, त्यस्तै एनसिडीका अन्य डिजिजहरू पनि के स्क्रिनिङ गर्न सकिन्छ भन्ने एउटा कार्यविधि बनाएर विशेष गरिकन प्राइमरी हेल्थ सेन्टरमा काम गर्ने स्वास्थ्य कर्मीलाई परिचालन गर्न सक्यौँ भने उहाँहरूले घर घरमै गएर चाहिँ ज्येष्ठ नागरिक भएको ठाउँमा चाहिँ स्क्रिनिङ गरेर सेवा दिन सक्ने पोली फार्मेसी छ कि छैन. एउटै बिरामीले अब 2-3 वटा डाक्टरकोमा जाँदाखेरि सबैले पिपिआई प्रेस्क्राइब गरिरहेको हुनसक्छ. मुटुकोमा जानु होला, ग्यास्ट्राइटिस भएकोमा जानु होला, युरोकोमा जानु होला, सबैले अब सँगसँगै के हुन्छ त भन्दा त्यही प्रोटोपम्प इन्हिबिटर नै प्रेस्क्राइब गरिरहेको हुनसक्छ. तर त्यसलाई एकत्रित रूपमा सबै प्रेस्क्रिप्सन हेरेनौँ भने सेम औषधि पनि खाइरहेको अवस्था र अब 5 अथवा सोभन्दा बढी औषधि खाने ज्येष्ठ नागरिक त धेरै नै हुनुहुन्छ. अब त्यसको कम्प्लायन्स के छ भन्ने कुरा पनि हेरिदिउँ भने त्यसबाट पक्कै पनि केही न केही फाइदा हुन्छ. र यसको लागि चाहिँ अब तिनै तहको सरकारको पनि समन्वय र सहकार्य चाहिन्छ. सङ्घीय सरकारले मात्रै गरेर पनि अलिक गाह्रै हुन्छ, किन भन्दा स्थानीय अन्तर्गत बेसिक हेल्थ सर्भिसहरू सञ्चालित भएको कारणले गर्दा यो मोडालिटीमा गयौँ भने आगामी दिनमा ज्येष्ठ नागरिकलाई क्वालिटी सर्भिस दिन सक्छौँ. र यस्तो मोडल चाहिँ सुरुवात नभएको होइन. मोरङको एउटा पत्रीमा चाहिँ त्यहाँको स्वास्थ्य कर्मीलाई परिचालन गरेर अलिकति सुरुवात गरिसकेको छ. तर उहाँहरूलाई यसरी स्क्रिनिङ होलिस्टिकमा जानुपर्छ भन्ने क्षमता अभिवृद्धि छैन र होलिस्टिक नभए पनि केही न केही सुरुवात गर्नुभएको छ. र यसरी हामीले होलिस्टिकमा स्क्रिनिङ गर्ने टुल सङ्घीय सरकारले बनाएर ओरिएन्टेसन दिन सक्यौँ भने ज्येष्ठ नागरिकहरूलाई चाहिँ आगामी दिनमा पक्कै पनि सहज हुन्छ होला जस्तो लाग्छ. र हामी सबैले आफ्नो आफ्नो तर्फबाट अब रिसर्चर्सहरूले पोलिसी मेकिङको लागि इभिडेन्स दिने र सम्बन्धितले गऱ्यौँ भने राम्रो हुन्छ भन्दै सम्पूर्ण प्रेजेन्टरहरूलाई चाहिँ बधाई तथा धन्यवाद दिँदै सेसन पनि के हो मैले ह्यान्डओभर दिएँ उता म्याडमहरूलाई, अब अर्गनाइजरलाई. हस्, थ्याङ्क यू.
Thank you to all the presenters for sharing your work so thoughtfully. Your presentation have added fresh perspective and help us to better explore the issues of aging and geriatrics in context of Nepal. Now, to recognize your contributions, I now invite our session chairs to come forward on the stage and present a token of appreciation to our presenters. To all the presenters, as I call your name, please come forward on the stage to receive it. Miss Kavita Aryal. Ms. Sandhya Khatri. Mr. Rohit Agrawal. Dr. Rekha Timal Sinha. Ms. Kritika Shrestha. A heartfelt thank you to all the presenters for the dedication and efforts you have put into your research and presentation. Now I'd like to invite Professor Dr. Mrigendra Raj Pandey, Emeritus Chairperson of NHRC, to come forward on the stage and present a token of appreciation to our session chairs. Okay. I also request all the presenters to please join on the stage with our respected chairs for a group photograph. Sorry. This brings us to the end of this session. With this, I would like to request you all to join the closing session in Hall A. Have a pleasant day and thank you once again.